Up next, Anthony DeMaria is joined by Dr. Mark Link, professor of medicine at Tufts University in Boston. They discuss acute exposure to air pollution triggers atrial fibrillation.
So, Mark, I'm surprised that there's no definitive information about the potential of air pollution to trigger atrial fibrillation even prior to your study.
Yeah, the difficulty with atrial fibrillation is so many episodes are asymptomatic or minimally symptomatic, and so you don't know when the onset occurs. And that's very different than ventricular arrhythmias and sudden death, where you know the onset, and therefore it's been much more difficult to study the association of atrial fibrillation with air pollution than it is to study sudden death and ventricular arrhythmias with air pollution.
And I guess the way you overcame this difficulty was by examining patients with ICDs.
Yes, for our study, we only took patients with dual-chamber ICDs, and these dual-chamber ICDs had leads in the atrium and the ventricle, and so they would record and document all episodes of atrial fibrillation and give us an electrogram of the AFib and also give us the onset down to the second. So we could use this data to much more accurately compare the association of air quality to atrial fibrillation.
Of course, I guess the price you pay for that is that you're looking at a unique group of patients who I assume had left ventricular dysfunction, probably significant cardiac disease.
Yeah, all of these patients had ICDs and had a current indication for defibrillators. So clearly they had underlying heart disease, and that clearly puts them at higher risk for atrial fibrillation. But to overcome that issue, each patient did serve as their own control in a case control series so that we compared the air quality levels at the time they got AFib to the air quality levels to times when they did not have AFib. So we weren't using them, comparing them to normals, we were using them as their own controls.
Right, but these data may not be readily extrapolatable to a normal population, let's say.
I agree that that's a potential issue, but I do think that, certainly if you look at the eighth decade of life, 20% or so of Americans will get AFib. So there's a tremendous amount of AFib out there and people susceptible to AFib.
How did you measure air pollution? How does one go about doing that?
Well, there are two types of air pollution. There's particulate air pollution and there's gaseous air pollution. The particulate air pollution was measured on the roof of the Harvard School of Public Health, in special chambers that are devised to estimate or to measure the sediment. And the gaseous air pollution was measured at a couple of places throughout the state, but predominantly at Logan Airport, again using special monitors for this pollution.
How accurate can the air pollution measurements be in terms of temporal sequence? Can you measure it by the hour, let's say?
Yes, all these air quality measures are measured by the hour. Both the gaseous and the particulate are hourly measurements.
In your manuscript, you limited the patients to an area, as I recall, of 50 miles away from the Harvard pollution detector. But that still casts a large swath. I would imagine within a 50-mile radius, there must be some significant variability of pollution levels.
We actually limited it to 50 kilometers, not 50 miles, and the median distance from the air quality monitoring station was 20 kilometers. We also restricted our analysis to those just living closer than the median distance, and the associations were actually stronger when restricting the analysis to just the group that lived very close to the pollution station.
When I was in college, I used to collect tolls on the New Jersey Turnpike, and I can tell you in that toll booth that the pollution levels were probably not representative of the surrounding 30 kilometers, but I'm sure that's an unusual exception. What did you find?
Our hypothesis going into it was that the 24-hour mean measurement of air quality prior to the AFib would predict for AFib. Indeed, what we found is, although that did predict, the 2-hour window was a much stronger predictor of AFib. And in fact, the 2-hour window for particulate matter, 2.5 microns, was a very strong predictor for the onset of atrial fibrillation. And the longer lag periods of time, beyond 2 hours, the association started to lose, and by 48 hours, it was no longer significant for particulate matter. The other particulate matter, the other gaseous air pollution did not as closely correlate with AFib as did particulate matter. And interestingly, particulate matter is predominantly from motor vehicle exhaust.
So roughly how much particulate material are we talking about? Are we talking about really high levels, dangerous levels, the kind that prompt warnings for susceptible people to stay indoors, or were these levels even below that?
Yeah, that's what's actually probably most concerning about our study. Boston is a relatively clean air city. The EPA sets a standard of 35 parts per billion particulate matter 2.5. In our study, the actual mean particulate matter 2.5 was about 8, so well below the EPA's recommended limit. So if you're getting these kind of triggering of AFib in Boston, a relatively clean city, I can only imagine what it would be like in cities that have a higher quantity of air pollution.
Based upon your findings, are you now cautioning your atrial fib patients to be very, very careful in terms of the environment that they find themselves in?
The problem with particulate matter 2.5 is that it's not actually screened out by the current air conditioning systems and the current heating systems. And so the level of this particulate matter inside a house is the same as the level outside the house. So I think the most important thing would be for the reduction of this particulate matter in the environment, not so much the exposure, because I don't think you can do much about the exposure because it's equal exposures in and out of a house.
So this is a bigger problem than any individual patient can deal with, I guess. Again, would we think that this would apply to individuals who don't have as advanced heart disease, or would apply in the same degree?
I suspect that the relative risk increase of AFib would be similar across all populations. But if you have a healthy heart and are young, your risk of AFib is essentially zero, so I don't think that you're going to see any increase in that risk with air pollution. However, if you're 80, then your risk of AFib is not insignificant, and I suspect that that individual, even if they had no prior heart disease, would be more susceptible to AFib during high pollution days.
These are interesting findings. I suppose one could argue in the extreme that if a patient had paroxysmal atrial fib that was sufficiently disabling and not susceptible to either medical or ablation therapy, that they might want to live in the middle of Wyoming or something such to minimize their exposure to particulate material. That would be a fairly drastic change, but one that might make sense based upon your findings.
Be a drastic extreme to write a prescription for, but I do agree.
Yeah. All right. Thanks very much for sharing this data with us.
Oh, you're very welcome.